I've been talking about for the immunocompromised host, where we see a lower response rate to the COVID vaccine, a rather rapid reduction in the antibodies, and also a very low neutralizing antibody response rate. So this medication here can be considered as a possibility to as a treatment in patients who have pre-exposure to COVID. So this is a picture of how the COVID virus, the SARS-CoV virus, actually bind onto the ACE2 receptor. So basically, the receptor binding domain of the spike protein of the virus will bind onto the ACE2 receptor, and then it finds its way into the host cell. In the tixagevimab treatment, we see that these two monoclonal antibodies are able to bind on the spike protein of the SARS-CoV-2 virus, and of course they can bind onto two different epitopes of the spike of the receptor binding domain of the virus. So therefore, this makes the virus not able to actually bind onto the ACE2 receptor of the host cell. So how was it actually developed? So the B cells of people with actually prior SARS-CoV infection were isolated, and then progenitor monoclonal antibodies were actually isolated. Then they actually created the monoclonal antibodies CoV-2-2196 and CoV-2-2130, which is your Tixa, and this is your Silga. Now, not only that, they actually reformatted the FC region to contain the YTE modification to increase the duration, and the TM modification to actually increase the neutralizing activity of the treatment. So then, this is where we see the tixagevimab and the silgavimab, and both together they create Evusheld. So to just briefly explain about the two modification, which is the YTE and the triple modification. So the YTE modification actually modifies the antibody to have a 10-fold greater affinity for the FC receptor at pH of 6 compared with those lacking in YTE. So it actually promotes antibody recycling, increases the half-life from 19 to 34 days to 70 to 100 days, which is 4 times above the average. And it also maximizes the antibody localization to the mucosa, where the antibodies will actually be transcytosis into the upper respiratory tract, which is the point of entry for the SARS-CoV-2 virus. The triple modification, which is the L234F, L235E, and P331S, ablates the FC effector function. It reduces the binding of the FC gamma receptor and C1q complement proteins, therefore decreases the likelihood of immunopathology, therefore making it more likely to actually neutralize the COVID virus. And both of these optimizes the Evusheld treatment and the effectiveness against the SARS-CoV-2 virus. So in this phase 1 study, which looked at Evusheld, it rapidly achieves the peak serum concentration, and it's expected to provide up to about 12 months of protection against the SARS-CoV-2 virus after a single dose. And you can see over here that there are different levels and doses. So the dose that's given is the 300 milligrams intramuscular injection, and the effectiveness is seen there up to 12 months. Now, the combination of the Tiga and Tixa and the silgavimab actually is synergistic, and it gives an overall synergy score of 17.4. By using it as a cocktail, the dose of each monoclonal antibody can be reduced by more than 3-fold to achieve same potency of virus neutralization. And this is important because of the dose that's given. Rather than a high dose of 3,000 milligrams, it can actually be achieved at 300 milligrams. Therefore, having the ability to actually use it for more greater number of patients. And both the Tixa and silgavimab, as mentioned earlier, binds onto different and distinct non-overlapping neutralizing epitopes, and therefore it neutralizes the condition. And finally, this is an activity against the Omicron. which actually shows that the live neutralization assays between 147 to 273 levels. So in conclusion, the effectiveness of COVID-19 vaccines is reduced in individuals with impaired immune function. This includes patients immunocompromised due to underlying health conditions and who are taking immunosuppressive drugs for other medical conditions. The Tixa-Zilga is a long-acting antibody combination that comprises two monoclonal antibodies derived from B cells of convalescent patients after their SARS-CoV-2 virus, and basically they retain a good inhibitory activity against all variants of concern. And finally, there is actually still this high unmet need for individuals that are at high risk of infection, especially our current chronic hemodialysis population. And that would also mean another option if they're not able to take their COVID vaccination. And with that, that's my last slide for the talk.
Thank you so much, Dr. Alvin. So we'll give the time over to Dr. Wong, who will give his infectious disease-related specialty advice and sharing on EvoShield. Dr. Wong. Dr. Wong, you're muted, please.
Yeah. Sorry. Okay, thank you very much to NKF and also to AstraZeneca for inviting me to give this talk. I'm going to just go straight into my talk and just to maybe to just recap. See, I can't seem to be moving my slides. Can you all see my slide change?
No, we can still see your first slide. If there's an issue, we can have Noura share it from her end.
Maybe Noura, you can take over. I can't seem to move my slides.
No worries, I can share your slides on my end, Dr. Wong.
So I'll stop my share.
Stop. Yep. Can everyone see my screen?
Yes.
The Wong slide? Okay, great.
Okay, next slide. So just to recap, I think Alvin has mentioned to you about COVID-19 infections in patients with CKD, end-stage renal disease, and renal transplant, and they are a vulnerable group. And we have the vaccine, which is quite effective, but the vaccine efficacy is reduced in these patients. So obviously, we have a gap in our infection prevention. And so today's talk will really be on the role of these monoclonal antibody combinations in both pre-exposure and post-exposure prophylaxis against COVID-19 infection. Next slide. Okay, so just to tell you that Evusheld, they have been looking at the use of these monoclonal antibody combinations, both in prevention, in post-exposure prophylaxis, and also in subsequent where there's both established infection where you give it both as an outpatient and as an inpatient. All right, next slide. So I'll just be talking primarily on two parts of their trial program. One is on PROVENT, which is the pre-exposure prophylaxis, and then the post-exposure prophylaxis is called the STORM Chaser, and that's really for when patients are exposed and they are at risk for getting infection, and sometimes it kind of flows into preemptive treatment because sometimes you can't tell for sure. So let's just start off with the PROVENT, which is on pre-exposure prophylaxis. So the target population is really those who have increased risk. Either they have not been vaccinated or they have an inadequate response to vaccination. All right, and of course we focus primarily on patients who are at an increased risk for severe disease from COVID-19 infection. Next slide. Okay, so this is the objective. Involves the Evusheld, which is a combination of Tixa and Silga. They are given in 2 separate vials and given as intravascular injections at 2 different sites together. And the trial is actually against placebo for pre-exposure prophylaxis. Next slide. So the study design, it's important for me to highlight a few things in terms of key inclusion and key exclusion criteria. So inclusion criteria in the trial, which actually was completed last year, it's focused on adults 18 years and above who either have no inadequate response to vaccination, and they must have, at the time of enrollment, they must have a negative point of care test, for COVID-19 infection. The exclusion criteria is if they recently had COVID-19 infection. They also excluded patients who had SARS and MERS in the past. Okay, and in this trial, it's important that they have no prior vaccination or no prior monoclonal antibody treatment for COVID-19 infection. All right. So it's a placebo-controlled trial. The patients got vaccinated. It's randomized at 2-to-1, and then the efficacy, they have studied it until about 180 days, and then they also looked at the safety up to 15 months. Next slide. Okay, so in terms of if they get infection, what are the criteria for diagnosing a COVID-19 infection? And this chart is, I think, familiar to all of you on the symptoms and things like that. Next slide. Okay, so essentially we are looking at patients who are adult population, patients who can benefit from passive immunization, meaning that they did not respond well to prior immunization. And of course, they are stable, and they are actually at increase for SARS-CoV-2 infection and also for severe disease. Okay, next slide. And so in terms of the study population, the majority, they divided, they had, remember it's from 18 years and above, they had about 57% who were less than 60 years and 43% who were more than 60 years. This is a trial that was done mainly, I think, in the US and some other Western countries. So the vast majority of patients were Caucasian, white Caucasian, and then a smaller percentage were African Americans and also from the Hispanic population. All right. Numerous 78% of patients had baseline comorbidities like diabetes, obesity was quite important, cardiovascular disease, cancer, CKD, and chronic lung disease. All right. Next slide. Okay, so if you look at the patient characteristics, for CKD it was 5.2%, 43% I mentioned were more than 60 years of age. A fair proportion, 41%, were actually obese, and again, 3.8% were immunosuppressed. So when you look at both the trial, the ones that received Evusheld and those that received placebo, I would say that their fairly well matched in terms of the study population. All right, next slide. Okay, so in terms of the exclusion criteria, I think we've kind of mentioned, but I wish to highlight that when they did the trial, the patients did not have either prior COVID infection or they did not have a licensed vaccine against COVID-19. All right, next slide. So if you look at the primary outcome in terms of the incidence of SARS-CoV-2 infection, you find that at the time point of 3 months, the risk reduction was 77%. So basically, Evusheld resulted in 77% reduction in SARS-CoV-2 PCR positive symptomatic disease when they compared it to the placebo group. So that's quite good. Next slide. This is just a schematic on what it looks like. In terms of the safety and tolerability, again, you see that the adverse events are quite well balanced between the Evusheld group and also the placebo group. Next slide. When you so I think that's pretty similar. Most of them of the adverse events were mild to moderate severity. Next slide. So, but I mean, to understand this, I think most of us are aware that our risk for COVID-19 infection is a cumulative risk. So as the months go by, your risk kind of goes stepwise upwards. But you can see that in the placebo group, it goes stepwise upwards, whereas in the Evusheld group, it remains quite static. Next slide. So when you look at the efficacy against symptomatic COVID-19 infections, when you look at the different subgroups, either by age, above 60, below 60, male and female, and between races, I think you find that most of the plot, you can see that it actually favors Evusheld as opposed to placebo for this pre-exposure trial. Next slide. So this is now a graph actually of the 6-month follow-up. And when you look at the 6-month data, Evusheld reduced the risk of symptomatic disease by 83% at the 6.5-month follow-up in this trial. Next slide. And so really, the summary is that that in patients at increased risk for inadequate response or increased risk for of CoV-2 infection, the study actually met the primary endpoint at reducing the incidence of symptomatic COVID-19 infection at 77% compared to the placebo group. When you look at the follow-up, the longer follow-up of 6 months, this risk reduction increased to 83%. So in terms of safety, these antibodies at primary or 6-month analysis, there was no cases of severe or critical COVID-19 infections in those treated with Evusheld, whereas in the placebo group, there were 5 cases. So I think based on this, it's actually received registration in the US. It has not received full registration in Singapore as yet, but it is available through the special access route in Singapore by MOH and HSA. Next slide. Okay, so now I'll just move on to a few slides on the post-exposure prevention. Remember, post-exposure prevention, you are either preventing it completely, like post-exposure prophylaxis, or it may be preemptive treatment, or PET, in which the patient has not developed symptoms yet. And this is also important target population because we want to treat them before they get severe disease. All right, next slide. Okay, so as you know, once the virus enters your body, really it enters very rapidly and then replicates within really 30 minutes, mainly in your upper respiratory tract. And then unfortunately, if you are in the unlucky few, it can go and invade the lower tract. And of course, after day 3, it's basically a disseminated disease. So remember, COVID-19 is a multi-system disease, not just the respiratory tract, right? And within 1 week, if you don't have any good immunity, you have about 1 billion virions or 100 billion virions during your peak infection. Next slide. Okay, so for this post-exposure prophylaxis trial, it is again the same. They give you the same dose at 300 milligrams. The trial design is 2-to-1 randomization, and the primary endpoints again, they look at COVID-19 symptomatic disease within the first 183 days. They look at tolerability, all right, and they look at severe disease, and then also the post-treatment response to antibodies, all-cause mortality, etc. Next slide. Okay, so again, the population on trial for this post-exposure prophylaxis, again, I wish to highlight that they are unvaccinated adults, and they with confirmed exposure to a person. And in this trial, they were allowed to be exposed up to 8 days before they were given the post-exposure prophylaxis. All right. So if you look at the reduction, and if they were, it didn't meet its full criteria. Let me just make the. In terms of relative risk reduction, when you look at all the patients, the reduction was, the relative risk reduction was 33%. But when you look at, you dive down into more details, if you look at only PCR negative patients, the risk reduction was 73%. And also, when if the patient was received the Evusheld and the onset of the post-exposure was more than 7 days, the risk reduction was higher at 92%. All right, so this trial focused really on the post-exposure prevention of symptomatic disease. All right, next slide. So I think perhaps I will start off before going into more details with a case study. So this is a patient that I saw very recently, just last week. Is a 56-year-old man. Next slide. He's got underlying diabetes, hypertension, dyslipidemia, and he's got minor ischemic heart disease. He had CKD and had preemptive cadaveric renal transplantation 6 years ago. He's on PrEP, tacrolimus, and mycophenolate, and unfortunately recently had chronic rejection, and his prednisolone dose had recently been bumped up to 30 milligrams per day. Okay. He had received 3 doses of Moderna vaccination, with the last in October 2021. He had not received his 4th dose. And after his last dose, his 3rd dose of Moderna, his antibody levels were actually quite dismal. And at only 3 international units, and his CPAS showed obviously no neutralization. He was advised to take the 4th dose, and he was vacillating whether he should take, because he never got an antibody response at all. So anyway, unfortunately, next slide, he went out for dinner with a friend and his friend's son, and his friend's son the next day, informed him that he was tested ART positive. So he was referred to see me, and then essentially, knowing that he had a very suboptimal, poor humoral response to 3 doses of vaccination, I then I gave him Evusheld 300 milligrams for post-exposure prophylaxis. But let me just go through very quickly the guidelines that NCID had published at the end of April with regards to the use of pre- and post-exposure prophylaxis. So NCID, based on the findings, they have advised that Evusheld should be considered in patients for pre-exposure prophylaxis, and if they have been exposed, and if they have like a moderate or severe immune compromise, or they are known to have not mounted an adequate immune response to COVID-19 infection, as evidenced by low S antibody levels or neutralizing antibody levels, of which our patient had both. They obviously do not want for it to be a substitute for patients who avoid vaccinations. Okay, next slide. And so, again, if you look at the immunocompromised definition, transplant patients are included, those who have cancer, hematological cancer, end-stage kidney disease on hemodialysis or peritoneal dialysis. Okay, and for those who are immune compromised. So before I move on to my concluding slides, I just want to emphasize that in transplant patients, we really cannot be giving Paxlovid because there's significant drug interaction with drugs like tacrolimus or sirolimus. Okay, next slide. So let me just conclude. I think that hopefully you all are already aware that in patients with CKD, dialysis, renal transplant patients, when they have COVID-19 infection, they have a poorer outcome compared to the general population. Next slide. And the humoral antibody response to our current available COVID-19 vaccinations is suboptimal, both in our dialysis populations and also obviously in our renal transplant recipients. And so a combination monoclonal antibody like Evusheld for pre-exposure and post-exposure prophylaxis should be considered in patients in such a setting. So with that, I'd like to end, and I think we're going to take questions now. Okay?
Thank you so much, Dr. Wong. So I think this was a very useful sharing by both Dr. Wong and Dr. Ang. There's quite a few questions. We have about 15 minutes left, and actually we're in the process of making a workflow for NCare patients. So I think we'll get into some practical details and questions as well. Let us start with the first one. For HD patients, should Evusheld be given post-hemodialysis or non-hemodialysis? Are you aware of any guidelines or practical workflows regarding Evusheld in dialysis patients? Both Dr. Wong and Dr. Ang can try and answer, please.
As far as I know, it's not dialyzable. Alvin, you may want to clarify that.
Yeah.
So it really has no
Yes.
impact on when you give it.
Yes, correct. I think I looked at the FDA guidelines for Evusheld and also from Nura, who provided the product information leaflet. It's not removable by dialysis itself, so it's safe to give anytime. So it doesn't need to be scheduled after dialysis or anything. So not removed by dialysis.
Yeah. So I think, when you are planning all these on a practical basis, it is essentially opportunistic. I mean, if they are there, you just give it to them. It's just like vaccination. You don't schedule them on a non-dialysis day and make them come back on a separate day. I think, wouldn't you agree?
Yeah, the timing, we have our patients here 4 hours, 3 times a week. We definitely got a captured audience then.
I think in NKF traditionally we have been giving some vaccinations on non-hemodialysis days because there was a question about some hematoma or intramuscular hematoma and all of that with the anticoagulation on dialysis. But I have also done a lot of literature search on it. I really don't find any evidence base for what we do. I think it's one of those things that have been traditionally going on. So Alvin, being a nephrologist, do you know anything about giving?
Yeah.
Yes.
So there's some vaccinations that we give to our patients, and I tend to give it even though they're on their dialysis day. I would be a bit cautious if they're on the heparin and dual antiplatelets. I may defer that to non-dialysis day for that sort of scenario. But generally, I think because I know that this is an intramuscular injection, and if they were not on, say, for example, like dual antiplatelets, then I would say it's relatively safe. I've not seen any of my own patients bleeding excessively from intramuscular hematoma. Yeah.
So I think probably we can give the take-home message to our nursing colleagues that this can be given on dialysis days, unless we are aware of some bleeding diastasis or some other bleeding problems for the patient, then we can try and put it on non-dialysis days. But for ease of administration, especially if NKF is going to be giving the drug, then having a captive audience, Alvin, like you've mentioned, so I think we can probably do it on dialysis days. Any objections from both Dr. Wong and Dr. Alvin regarding what I've just mentioned?
Nothing for me, but I just want to emphasize another point. The volume that you are giving is 1.5 mils on for each vial. So the volume is not like excessive. So I think it should be fairly safe. I mean, just give it intramuscularly. I think the current recommendation is into the buttock or the lateral thigh, but many of my patients just take it in the deltoid area.
Okay, great. Any comment on whether now that the second booster dose or the fourth dose is coming up, should there be any consideration of giving it before or after the fourth booster dose? Oh, sorry, the fourth dose?
I think that currently most of what we are doing and recommending are essentially in patients who have a suboptimal antibody response. I think currently we only have available a humoral response to look at. I mean, of course, you could argue till the cows come home about T-cell response and things like that, which we don't have a commercial assay for. So I would say that I would limit it to patients in whom they are known to have a suboptimal antibody response.
Okay, sure. So I think that leads to the next question. I'll probably bundle it all up, and that is whether we should be checking antibody levels before giving the injection. For ease of administration and logistical considerations and workflow considerations, we don't have a means of actually checking antibody levels. They come every 48 hours, or if it's on a weekend, over 72 hours for their treatment. So if we check something, we may not see the patient for 2 days or 3 days. Would it be feasible to say that if we have, say, for a post prophylaxis or even pre prophylaxis, if the patient is symptomatic at higher risk, we go ahead and give Evusheld without checking antibody levels? Would you like to comment on that, please?
So I would say that checking okay, there are two aspects. One is pre-exposure, one is post-exposure. I suppose the post-exposure are a bit more stress because you really want to give it as soon as possible. And I know the trial is 8 days, but typically in our practical workflow, we try to limit it to within 5 days. Because I think the earlier you give it, the better. More likely you're actually able to prevent infection, although we never guarantee that, but I think we do tell our patients that we can quite safely prevent severe disease for post-exposure. For pre-exposure, I think you have, I would be reluctant to say that all dialysis patients get Evusheld. And even for the transplant population, it's about 50% of them who get basically no seroconversion. So in those populations, the answer is, I think you can give 3 or 4, it makes no difference. After 3, they got no antibodies. The 4th, I think, is not going to make any difference. In those patients, I think you should focus on getting Evusheld. But in the dialysis population, actually your seroconversion with vaccination is actually not bad. The problem with the dialysis population is that antibody levels drop quite quickly. That's my understanding of the literature, and Alvin may have some comments on that. Is that your opinion too, Alvin?
Yeah, so I have meetings with other colleagues internationally, and during the beginning of time, during the primary vaccination, before the booster was recommended, we were seeing a lot of patients where the antibody titers were actually dropping quite significantly. And also, I think in one of the slides I showed earlier, in just 6 months, I think about half the patients would have low antibody levels for anti-spike. There was this other thing I was wondering about, that neutralizing antibody. Dr. Wong, I just wondered, even with the antibody being present, they don't seem to be able to mount a response against the COVID infection, isn't it, in this population?
Yeah. So, okay. So let me try to figure out how best to answer it. So the antibody level, at least for the assays that we have in Singapore, if your S antibody level is quite high, meaning it's above 500, you almost certainly will get reasonable neutralizing activity. It's not a one-to-one correlation, but I think you could predict that if your S antibody level was more than 1,000, you definitely get more than 50% neutralization, which is probably sufficient for most patients. And in our current setting, for most of us, take estimate of 500 international units as being protective. Of course, we will be advised by further research and further reports on whether this 500 is a good level or it can be brought down to be lower. So that's for the antibody levels. We do get breakthrough. Even if you have 2,000 international units of S antibody by the Roche assay, you can get breakthrough infections. You can have a CT value of 15 or 18, but you typically don't get severe disease. So I think those would be my comments.
Okay, great. So in the interest of time, I think two burning questions. Are there any exclusion criteria for patients who should not be receiving it?
Evusheld.
Yes.
I would say that it's really allergic reactions.
Okay.
Okay.
And yes, please.
Anything else, Alvin?
No, I can't think of. Yeah.
Okay, so I think maybe we can come up with some recommendations on our workflow and how we should go about it. So there is pre-prophylaxis, there's post-prophylaxis. All of our patients are ESRD, they're at risk. Regardless of their vaccination status, would you give us some kind of a working guideline on how we should go about giving them Evusheld?
I think this remains I think this is an evolving situation, and this needs to be discussed because clearly there's a proportion of the population, like transplant patients, patients on steroids, even patients who had rituximab 1-2 years ago, they never produce antibodies. And giving them 4th, 5th doses of vaccination, I think are not going to help. I think in those populations, I think on a practical basis, it's good to check their antibody levels. For the dialysis population, I would say that perhaps maybe because NKF it's got a big pool of population, maybe you should look at how quickly the antibody levels drop after 3 doses and 4 doses. And then the strategy then would be either give them more doses of vaccine or give them Evusheld. But Evusheld, we think that it will definitely give protection for about 6 months, maybe longer than that. I think AZ mentioned that it can be up to 12 months, but we would usually want to review the situation after 6 months. So I guess for most of the dialysis patients, because they do produce, most of them do produce, they still convert and produce antibodies. The issue is, what is the protective level, and are you using a strategy of vaccination, or are you using a strategy of Evusheld? The latter, I think, is going to be more expensive if you are paying for it.
Sure. Thank you, Dr. Wong. Alvin, what do you think, knowing all the nuances of our dialysis schedules and all of that?
I think I can't summarize it any better than Dr. Wong earlier. I think the only part I can think of is about the patients who already had the COVID infection. I think they probably be the population that would be excluded from the Evusheld. But other than that, I think I will echo what Dr. Wong has mentioned.
Okay, sure, sounds good. And I think there's another question, do they need repeat injections? And I think Dr. Wong just mentioned that AstraZeneca has mentioned that it lasts for about 6 months, perhaps a year. So depending on the risk profile of the patient, and we can decide on whether they need repeat doses. Any concern about giving this with concurrently with other vaccinations? So if a patient is having a COVID injection, can it be given the same day, or does there need to be a gap? And the same question applies to other vaccinations as well.
Theoretically, no, but generally we don't like to give a vaccine and a passive antibody at the same time. So we would try to avoid that. So the usual standard time interval is anything from 2 to 4 weeks.
Okay, thank you so much. So I think we have exhausted our 1 hour. I think a lot of take-home points for us. I think we'll have to collate, and like Dr. Wong and also Dr. Alvin has mentioned, we need to have an internal discussion to kind of see how best to implement this in our dialysis centers, keeping in mind our logistical issues as well. So I think there have been some recommendations from the manufacturer, AstraZeneca as well. Also, MOH is also trying to give us some tips on how to make it a bit more easier to administer. Granted, we may have to skim a bit on the antibody checking that is ideally done in the hospital setting, but in our community-based dialysis setting, I think that would be something that we would need to see how to best weigh the pros and cons. Dr. Wong, would you consider that we can manage this on our own with protocols and all of this, or do we need to get an infectious disease doctor involved?
I think that you can come up with a protocol. I think the chapter of infectious disease physicians would be more than happy at the Academy of Medicine would be more than happy to assist NKF and come up with some position paper or some joint recommendations.
Yes, definitely. Actually, we did have an advisory board with a panel, so I think they gave us some useful tips, which I'll pass on to our nursing colleagues as well. So I think a very good session. Thank you so much. I think there was a lot of unease and anxiety with in our nursing staff when I told them about EvoShell. So hopefully some of those fears have been allayed today after hearing both of you. So thank you so much for that. Any final comments for NKF before we adjourn?
No, thank you for the kind invitation.
Okay, Alan, from your side?
All good. Thanks again for this very interesting session.
Thank you so much. And before we end, it's Kuldep's birthday today, who's our head of nursing as well at this time for Pauline. So happy birthday, Kuldep. And thank you, thank you, Noora, for arranging this.
Thank you
and
so much.
Yes, we'll be in touch. Thank you so much for both speakers.
Alright.
Greatly appreciate your time.
Sorry. Can I just take a very quick screenshot of four of us, if that's alright?
Sure, absolutely.
Okay, wait, just prepare your smile. Alright. 1, 2, 3. Oh no, sorry. One more time, yeah. 1, 2, 3. Thank you.
Okay, thank you so much. Have a good afternoon. Take care. Okay, bye-bye.
Okay, bye.